Hi everyone, it's the Health Education Podcast, and I'm here with Maddie, Phoebe, Radha, and Sophia, who are second year nursing students, and they're going to discuss everything you need to know about delirium. Just to give you an overview of delirium, it's a complex condition that can be difficult to diagnose. It's often associated with long hospitalization stays and or loss of brain function. It mainly affects the older population, being 65 years and older, and is considered a mental emergency. It is often mistaken for dementia, but the key difference between each other is the sudden onset that delirium has, where dementia is developed over time. For nurses to distinguish between the two, they will need information of a baseline mental status and changes in cognition of the patient. When nurses assess a patient that is presenting with delirium symptoms, they will need to distinguish what kind of delirium the patient is having, as there's 3 different kinds of delirium, one being hyperactive, another being hypoactive, and the third one being mixed delirium. But when it is treated effectively, it can usually resolve within 4 to 7 days. In regards to the pathophysiology, it is unknown, but theories are thought to be related to multiple mechanisms, the main ones being inflammation, hypoxia, and neurotransmitter imbalance. Delirium is a dysfunction in the homeostatic response to a precipitating factor, being medical or surgical condition. The most common causes of delirium are dehydration, infection, and the use of anticholinergics and opioids. For the first one on inflammation, variable stresses can cause an increase in cytokines that can affect neurotransmitters. When the body is under stress and starts inhibiting the immune responses, anti-inflammatory cytokines are released, and these cytokines trigger an exaggerated neuroinflammatory reaction, which will then affect the synaptic and neural function. When the synaptic and neural function is affected, cognitive and behavior symptoms similar to delirium is present in the patient. And this is common with post-operative and immunocompromised patients. For hypoxia, it's a decrease in oxygen in the brain, possibly caused by neurotransmitter concentration. There is something called hypoxia-induced post-operative delirium, which causes a decreased synthesis of acetylcholine. Conditions that cause delirium are those that prevent oxygen or other important substances from reaching the brain. For the third one, neurotransmitter imbalance, it's a high anticholinergic activity that has a 100% predictive value for delirium. The cholinergic system is a neurotransmitter that is linked to several essential brain activities, being arousal, attention, sensory input, memory, and REM sleep cycle, which are all affected when delirium is present. For hyperactive, hypoactive, and mixed delirium, different symptoms will arise for each. For hyperactive delirium, you'll see restlessness, psychomotor agitation, and hypervigilance. This is a more exaggerated response and symptom, so it is easier to detect for nurses. For hypoactive delirium, you'll see lethargy, drowsiness, and decreased motor activity. This is the most common, but does often go unidentified because it can be mistaken for depressive symptoms. And the third one, mixed delirium, it has features of both hyperactive delirium and hypoactive delirium. Other symptoms of delirium are hallucinations and disturbed sleep. The 3 changes that occur during delirium state is 1 being the disturbance of attention and awareness of one's environment, 2 changing cognition, 3 development of the disturbance over a short period of time, and it fluctuates during the day. The onset is acute, the duration can be days to weeks, and the course is fluctuating. For complications of delirium, the most common complications are functional decline, longer lengths of stay in hospital, and self-extubation, such as removal of catheters. Other complications are malnutrition, aspiration pneumonia, pressure ulcers, decreased mobility and function, and falls in combative behavior. For malnutrition, it's a fluid and electrolyte imbalances. Since malnutrition causes cognitive dysfunction, delirium symptoms will arise because of this. For aspiration pneumonia, delirium may be the only manifestation to indicate that pneumonia is present. For pressure ulcers, due to the longer hospitalization stays of delirium patients, pressure ulcers are common, as they're majority of the time in bed. Decreased mobility and function. During states of delirium, patients are medically controlled to the episode. This results in a sedative state where the patient will not be able to be as mobile as they usually are. And the last one falls in combative behavior. Cognitive impairment is effective, therefore the combative behavior occurs resulting of this. This is results for potentials of falls, which would lead to injuries and fractures.
So next we're going to be discussing best practices. So these are tools, assessments, and just steps in ways to care for someone that has delirium.
The CAM assessment tool is a tool that can be used to assess for delirium. The CAM assessment tool looks at things such as an acute onset or fluctuating course, inattention, an altered level of consciousness, and disorganized thinking. Based on the score that's received, it can be determined if a person has delirium or not.
Management of delirium. As stated by the RNAO, management of delirium includes recognition and screening of early signs, followed by treatment and then continuous monitoring. When it comes to recognition, family and caregivers should look for early signs of delirium. Studies show that regularity of visits to a caregiver will allow for early detection, resulting in an improved clinical outcome. The primary caregiver can create baseline data and observe if there is a decline in mental and behavioral status. Since delirium is commonly confused with dementia and depression, it is important for the caregiver to be aware of the differences. If the caregiver recognizes changes in function, behavior, or mood along with disturbances of consciousness, it should be directed to a medical professional for urgent medical care. Treatment. When using pharmacological interventions to treat delirium, it is important to eliminate any non-essential drugs, along with minimizing doses of other medications as much as possible. Medication for delirium should be limited to psychotropic medication, which will be discussed in further detail in the upcoming slides. Some environmental factors such as light and noise may contribute to delirium. Allowing for familiarity by putting personal objects in the room can help with management of delirium. Putting clocks and calendars along with minimizing light at night can assist with reorientation and provide support. While it is important to treat the patient with delirium, there should also be support for the family. Family support groups and therapies are significant resources as they educate the family and patient on important factors of delirium. Finally, there's monitoring. After treatment is initiated, it is important for the family and caregiver to consistently monitor the patient as they are at great risk for falls. While it may seem reasonable to use restraints, studies have shown that restraint removal have been linked with a decrease in number of falls and injuries. Restraints should be used as a last resort measure when all other alternatives have failed. Using the delirium rating scale, the caregiver can recognize the severity of delirium and compare it to the baseline data that was collected during the recognition stage. Depending on whether it was intensified or improved, an update to the plan of care is necessary.
Although delirium varies amongst individuals, there are consistent medications and preventative recommendations for all strains of the disease. In terms of non-pharmacological prevention techniques, focus should be on reducing risk factors. For instance, nurses should advocate for medications and adjuvant therapies for pain management because pain can cause delirium to develop. Furthermore, in a study using the Hospital Elder Life program, delirium occurrence and severity was reduced through ensuring patients had adequate fluids, sleep, nutrients, and visual and hearing assistive devices. Also, reorienting patients to their surroundings, promoting mobility, and lessening the effects of alcohol withdrawal is effective in reducing delirium occurrence. Furthermore, known precipitants for delirium such as benzodiazepines and anticholinergics should be avoided because they can worsen mental status and cause oversedation. Although there is no medication that can completely stop the onset of delirium, medications such as antipsychotics can decrease the severity and duration of delirium. Haloperidol is a common typical antipsychotic used to treat delirium. It works through antagonizing dopamine receptors and disinhibiting acetylcholine. Antipsychotics can further deteriorate mental status and cause extrapyramidal symptoms. Therefore, patients should be put on the smallest dose for the longest time possible. In addition, atypical antipsychotics risperidone, olanzapine, and quetiapine have a similar efficacy to haloperidol, despite having a lower affinity for dopamine and causing less extrapyramidal symptoms of side effects. Alpha-2 agonists such as clonidine and dexmedetomidine are sedative hypnotic analgesics that allow arousal and cause minimum respiratory suppression, which can be used to reduce the effects of delirium. Non-pharmacological nursing solutions for patients with delirium include using clear instructions with frequent eye contact, being patient and respectful, limiting room and staff changes, minimum noise and low lighting at night. Furthermore, success in reducing the severity of delirium has been found through using a sleep regimen and respiratory therapy. Also, surrounding the patient with familiar items and people is beneficial in grounding them and reducing the effects of their delirium.
Delirium is reversible when recognized. However, nurses who are unfamiliar with a patient's baseline may fail to recognize the symptoms of delirium. This is why it's so important to include family or a caregiver when possible, because they're familiar with the patient's usual behaviors and are likely able to help with recognizing delirium early on. For nurses, the family or caregiver's familiarity with the patient can actually help organize the trajectory of patient care. However, a family might think that delirium symptoms are due to normal aging or even something like dementia, so it's important to provide health teaching and information for the family. Family and caregivers who are educated about delirium could partner with nurses and other healthcare professionals in being able to recognize symptoms of delirium. The outcome of educating families about the symptoms of delirium include an increased knowledge about delirium and an improved emotional state for the family members. As they know more, they feel less distressed. By providing health teaching to the patient's family, there can be vast improvement in the prevention, recognition, and care of a patient with delirium. It's important to provide families with resources that they can reach out to and use if needed. An example of this is the RNAO Delirium How You Can Help fact sheet. It's a great resource that families can use. It has a lot of helpful information that's presented in a way that's easy to read and understand. Thank you for joining us. We hope that you've learned some important information on the topic of delirium. That's all for now for the Health Education Podcast.